All right, everyone. I'm Amy Shea Reyes, she, her pronouns. I'm the Behavioral Health Manager for Children, Youth, and Families with CareOregon. If you were here in our last couple series, this topic came up a lot around consent. So I'm happy to introduce Wes Rivers from OHA and Jen Taylor from LifeWorks Northwest / Virginia Garcia.
Hi, everybody. My name is Wes Rivers. You see him pronouns. I am a Youth and Policy Partnerships Manager with the Public Health Division at OHA. Jen, do you want to introduce yourself first?
Hey, I'm a clinical supervisor with LifeWorks Northwest, but all of the work we do these days is with Virginia Garcia and primary care clinics in Washington County and school-based health centers in Yavapai County too.
So we are here to describe a very sensitive topic as well as one that is extremely complicated legally. I want to just preface this that we don't have all the answers or most of the answers. We're here to generate a discussion about this because it is something that's very important and it comes up every single legislative session. It's minor changes to the minor consent law. And I think it's vitally important because it's constantly changing, that we have open dialogue as community to really think through the implications of the changes, as well as open dialogue with the youth and families that you're serving. So I come from it from a public health youth engagement lens, and so you'll see that come through in this presentation a little bit, but I just wanted to put that out there at first because I know we get questions every day. And a lot of them we cannot answer. And so I just want to put that out there before we start. Here is our disclaimer. I have to read this, so bear with me. We are not attorneys. All procedure and practice questions should be brought before your legal counsel to advise on the applicability of state and federal statute. Given this, we will not be able to speak to specific instances, anecdotes, or local interpretations of consent and confidentiality, practice, and procedure. Just want to put that out there. Again, generative discussion. First, I want to kind of tell you a little bit about the role that OHA plays. Like I said, my colleague and I have a colleague for the Title 10 reproductive health section. We interpret statute every year as it is changed. Again, we're not attorneys, we're policy analysts, but we pretty much own the 109-600 series in the statute to interpret. Given that, people often reach out with legal questions, but we have seen the growth and expansion, the attempts at growth and expansion of the consent and confidentiality law since I started at OHA in 2016. What we try to do is provide guidance as much as possible, and we work with our partners at the Oregon Health Systems Division, Oregon Health Authority Health Systems Division, Behavioral Health Unit, Jesse's back there, to provide as much guidance as we can to the providers we provide grants and funding streams and rule interpretation for. So the big one that I'm sure you all have seen, and a new version is coming out based on this past legislative session, is Understanding Minor Consent and Confidentiality Healthcare in Oregon, which a large chunk of this presentation is lifted from. So if you're familiar with that document, you'll be familiar with this information. We have a behavioral health specific FAQ, which was just added to this document also. It's just published, what, Jesse, like a week ago? Recently. Yeah, very, very recently, specific to behavioral health services. And then OHA and ODE have talked a lot about what resources we have for school districts. So my program is primarily involved with clinical services related to school-based health centers and school nursing, as well as youth sexual health program provision. A lot of that is school-based. So understanding the complexities of both the healthcare system and the education system coming together on a single issue. Reproductive health is very similar in that way. We have to navigate both the laws that govern our healthcare providers as well as our educators. So we have an opioid toolkit, which is
a joint venture between ODE and OHA. That is also being updated with recent legislation, SB 238, around fentanyl and overdose curriculum in schools. So better understanding that. And then we have OHA has a Noxalone FAQ. I have links for all of that at the end of the slide deck. So let's just baseline everything. First is the consent statute. So there are three, this is kind of, we joke, but it's also really hard. It's kind of a choose your own adventure when it comes to consent statute. Medical and dental services, minors who are 15 years and older can consent to medical and dental services administered by a licensed provider without parental and guardian consent. That is ORS 109.640. So this includes all dental, optometric, and surgical services. And again, I'm doing this, I know for some of you this is very basic, but I think it's to make a point of like how complicated this is, especially in a system that's providing integrated and coordinated services. Minors often show up for one thing and they get services for something else. So I think it's really important to kind of walk through this. Reproductive health. This just changed with the passage of House Bill 2002. Minors of any age can access reproductive health care services and information from a licensed provider, the same definition as the medical and dental, without parental and guardian consent. This includes contraception, prenatal, postnatal, and delivery care, miscarriage management, fertility care, and treatments for STIs. And then finally, behavioral health. A minor who is 14 years or older may access outpatient mental health, drug, or alcohol diagnosis or treatment, with the exception of methadone, which we heard earlier from the speaker before, without parental and guardian consent, if those services are administered by a licensed provider listed in ORS 109.675. So licensed psychologist, licensed a medical doctor, naturopathic physician, a licensed clinical social worker, and a licensed family, forget the name of that, just marriage and family provider. Thank you. Okay, so that's consent. Then there's disclosure, which the tree grows out. Medical and dental. A provider may advise, may is the key word. It's up to the provider's discretion. A parent or guardian of the minor's care, diagnosis, treatment, or the need for any treatment without the consent of the minor. When a minor consents When a minor consents, providers are encouraged to use their best clinical judgment in deciding whether to share information and the parent or guardian. So again, this is up to a provider's discretion. Best practice is to always try to involve a parent or a caring adult or guardian, but the provider has that discretion at the end of the day. This is the same for reproductive health services, with some exceptions. And then for behavioral health, as we heard earlier this morning, for minors, best practice is that parents and guardians are involved by the end of treatment. And that is also what is in statute. So by the end of treatment, parents and guardians are supposed to be engaged. So I'm gonna now open this up to key considerations. So working in a school-based setting is extremely difficult because you are weighing the rules of the district policy versus what is the laws and rules that govern healthcare practice. School attendance policy we see, especially with respect to school-based health centers, is often a consent and confidentiality block for youth. So we have heard of really great practices in our school-based health centers, especially in navigating that the usage of utility and usage of services with attendance offices, and working out some understanding of how that shows up on an attendance record, what is necessary to notify a parent, and how that works with the youth totally understanding what is on their record and what is not. It is also even more difficult for youth leaving for an outpatient appointment off of campus, although that also exists with providers who have very strong ties with their school district that we've heard of. This is really thinking about outpatient clinical settings. Anything that happens within a school, as with respect to a provider who's either being contracted or there's some sort of MOU between the school and the district, there is no guarantee to confidentiality and consent policies. So anybody who is employed by a district they are an agent of the district, and the rules of the education system apply, including the student health record. For SBHCs, sustainability and confidential visits is a big issue that we hear a lot. So even with a minor consent statute, the youth who are on their parents' insurance, explanation of benefits that might go home, using the usage of confidential visits to maintain confidentiality as much as possible for a consenting minor, that is not a sustainable, over time, that is a very hard financial practice because you cannot bill. The other key is thinking about prescription. That is often a conversation that happens between the district and the SBHC provider. I've heard of the banning of certain prescriptions within a SBHC or distribution of, the thing I'm thinking of mostly is distribution of contraceptives. Some districts create explicit policies to not allow for the prescription of certain things on a campus. It's best to know what those are. We know of SBHCs who are prescribing Naloxone, so it's important to think about what the district policy is with respect to those services. Just got to the district policy piece, test strips. So test strips recently became illegal for any youth 13 years of age or younger who is not actively involved in treatment. So distribution of test strips, it's important to know the change in the law that just happened this past year, and something that we've heard back from our youth engagement that is quite problematic. And so I just wanted to make sure that folks were aware of this. There were multiple changes actually to the behavioral health law that Jesse and I worked at this last session. Those did not go through. Those would have made behavioral health accessible, mental and substance use treatment, outpatient treatment available at any age. The confidentiality statement would have stayed the same, but it would have mirrored reproductive health in that. Instead, they changed that whole section and added a ban on fentanyl test strips for youth younger than 15. So it's important to know that. And then stigma and consent. This is another thing that comes up a lot in our conversations with SBHCs, is you can have the best consent and confidentiality policy in the state. Getting youth to get into those services and actually consent to them is another thing. I really wish I was listening to this screening presentation, because I think there are practices that are happening around screening and universal screening to try to alleviate some of those barriers. SBHCs have come up with some great practices around group and creating spaces for youth who may or may not be using to have conversations to alleviate some of that stigma. And then we even have a couple of SBHCs with diversion programs. So creating programs for youth youth who may be at risk, who are caught with substances, and creating a way out of detention, expulsion, suspension. So there are several conversations that need to be had, and we will get to this point later, and my colleague Jen here will talk a little bit about this, and we will talk a lot about youth engagement and how to start having those conversations with youth serve.
Hi. Okay, so we in primary care see everyone, right? So that's across the lifespan, birth to death. So we see youth in primary care, but I would say the majority of the youth that we see are in our school-based health centers that are on campuses. We don't have any school-based health center that's in a high school at this time. They're just on the campus. So a school-based health center is technically a medical setting, right? It's a medical clinic. You can go there for medical care, but we are there as behavioral health clinicians. So the services that we're delivering they fall under the umbrella of behavioral health, right? Can you see how it would be really confusing when we're talking about consent versus 15 to 14 years old? Still have never gotten a clear answer from our QA department on that one. But for the purposes of current care, what we're doing is it's based on the service being delivered, right? So if you're billing a mental health CPT code, it falls under the behavioral health umbrella, and that's the age of consent is 14. Again, I still think it's very murky being in a medical clinic, but that's just where we ended up landing. So how do you inform a patient of consent in the process? How do you inform a youth? Like, how do you tell them this is what informed consent is? Does anybody have anything off the top of their head that's worked for you, that you love? You all have to do it every day, I guarantee it. So, like, what's working for you?
And talk about mandatory reporting. And then sometimes talk about risks and benefits of treatment, but I'm in integrated care, so I'm usually not doing a lot of long-term treatment.
Right. And do you feel like people know what you're saying when you tell them about this?
They usually nod a lot and try and rush me through it.
Yeah. When I did group in junior high, I remember we would be like, I'm gonna kick her ass. And the therapist would be like, you feel like you're gonna do that? Be like, oh yeah, I just feel like I'm gonna do that. So the way that you explain it later in practice, right, it matters, because it's gonna come up and you have to re-remind people, because I think they get caught up in their situations and what's going on. And I saw there was a lot of confusion in the community, specifically when 988 became a thing. There was this big blast on social media about how this agency calls the cops. And I'm like, well, yeah, they're mental health professionals, and sometimes that happens, right? And if you're not giving good informed consent, then people aren't gonna know and they're gonna get angry about it, right? So you have to be able to do that right up front, right away, make sure people know, and then continually remind them throughout the course of treatment, right? What else do I have in my notes here? Okay, so parents and guardians have the legal right to the record, right? When you're working with youth, so you have to make sure you're documenting accordingly. I supervise all of our unlicensed staff, and so I'm signing off on notes, and I'm scanning for that stuff every day. Like, what would it feel like to have these notes up here, right? So just make sure that you're documenting accordingly, because all sorts of eyes can be on your notes. What if, though, you are worried about a parent looking at the notes? What does that look like? Has anybody had that come up? I'm sorry to ask for participation, it's just more fun.
I could say in Epic, we can actually block the notes from that, so that's a function that is really useful.
Mm-hmm.
Yeah.
Yeah, we use Epic too.
Okay.
Mm-hmm. Mm-hmm.
I can't. I don't have that option to block the notes. And I just try to keep it as vague as possible while still putting in what's needed and necessary. And yeah, but I haven't had a parent explicitly ask to see notes, but I've had kids tell me I don't want my parents to see my notes, so I don't sign off on them. So.
Okay. It's tricky. Very tricky. So you can say, like, say this youth is 14, 15 years old and they don't want their parents to see, and the parent's like, hey, I want to know what's going on. And you can say, well, you have to get consent from your child, and like, I can't reveal, and all these things. But ultimately, they have right to the record, so they can turn around and go request it from medical records. So all the more reason to be really careful about what you're documenting in your client's chart.
Can you speak to that a little bit?
What do you mean?
Requesting that they can go turn around and request the record.
They can, because any parent or guardian, even if they're non-custodial, has right to their child's record.
Who are they requesting it, like through insurance?
Through the provider. So like for us, it would be through the clinic, right? The medical records department of our clinic.
Even though the child has said. Okay.
Yeah, it's very tricky. I just did ethics training on Tuesday too, so. We were just talking about this. I've been doing this 11 plus years, and I've only once ever not given a guardian their right to records, because there was an issue of safety, and we had lots of safety meetings about it to figure out, like, hey, we have really serious concerns about this non-custodial parent getting in here, because there was a very ugly custody battle happening, and the safety of the child was at risk. And so one time ever that I've said, can we not? And we determined that we could not. But once, that's kind of a big deal. Yeah, those are all my notes. I'm so sorry, I'm so techie dumb. Go down. I did get to the bottom. I feel like there's more down there. I'm sorry, I don't know what I said last week. Like, what other notes do I have?
Can I ask a question?
Please, ask a question. I'll probably just skip my notes. This is more helpful anyway.
So we work for Northwest Family Services, most of us at this table, and we do youth alcohol and drug counseling. And we do informed consent and privacy and all that. And we also have ROIs, information, IRs. And we tell the youth, here's your information release for your emergency contact. You can tell me what I can tell your parents. I'm hearing from you that the parents can know anything they want to know.
They can.
So that's really interesting because,
Yeah.
So I guess, how should we relay that differently, if you have any advice on that, so that I'm not lying, right, to the youth that I'm really trying really hard to build a trusted relationship with. Yeah, thank you.
A very great question. It's incredibly tricky. I would be as upfront as you possibly can and letting them know that, at the end of the day, these folks do have access to your record. So if there's a safety concern, I need to know about that. If there's something that you don't want in there, we have to talk about that and figure that out together. It's more of a collaborative process, right? I'm not saying it's easy and that there's a really amazing answer to that, because at the end of the day, you could have a real nosy parent who finds things out and it ruins things, whatever, but just having those candid conversations as soon as you possibly can. Sorry.
The 42 CFR Part 2 federal confidentiality, how is that in effect in this?
Yeah,
Substance
so
use
that
only.
does add another layer, right? When you're talking about substance use treatment, our folks don't provide substance use treatment, so that's an added layer. But I do believe that parents will still have access to those records, because it still falls under behavioral health, right?
I think if they're 14 and up, they do not. I work with Clackamas County, and our medical records will not give parent substance use records unless there's an ink sign thing. For 14 and over, we're just starting
do not, unfortunately. I'm sorry. So the substance use world is a little different for me.
Hey guys, let's try to use the mic for our recording so we can get all this good content online.
Hi, Wes has referred to me a couple times. I'm Jessie Egan. I use she, her pronouns. I'll be on stage in a little bit. I work for OHA, but also have worked on the provider side and as a therapist for a long time. And I wanted to kind of chime in on some of those pieces around the informed consent, particularly around substance use issues. And what I always found to be really helpful was to be having that informed consent conversation with parents in the room. So parents and kids at the same time can hear me say, parent, there are some things, you have access to the chart. All of this information does belong to you. And there are things that young people don't want me to tell you. And mostly those things have to do with sex and drugs. And so I'm gonna try to have some level of discretion. I'm not gonna tell you everything. If your young person comes to me and they say that they are smoking pot once at a party, they wanted to try it out, they're experimenting a little bit, I might not tell you that. If they tell me that they're shooting heroin and this feels like a really significant safety issue, you have a right to know that as a parent, and I'm going to, violate confidentiality and make sure that I tell you those things because you have a right to know about safety issues. And I make sure that the kid is present in that conversation as well so that everyone can hear that and everyone kind of knows, parent, yes, you're not gonna know everything, but young person, your parents are going to need to know something. So if you tell me something that feels scary, we're gonna have to have a conversation and I'm gonna say to you, this feels like the kind of thing that your parent should know, and I would then pass that on. That way everything is really transparent.
About half the kids I see, their parents don't know. I work specifically with high school kids and who are all over 14. Yeah. Nope, that was basically it. I don't ever really have a chance to have that conversation with parents.
So I want to preface this as not legal advice, okay? I just want to. So the law is silent on non-licensed providers. The law is silent. It doesn't say anything about non-licensed providers. So these conversations can happen with non-licensed providers about really going in depth about what are your rights. And I think we're going to talk about this in a second about some key practices on engaging youth from beginning to the end of treatment, where they are constantly involved in understanding what their rights are. So I'll save that for then. But I do want to say that there is a lot of gray when it comes to non-licensed providers engaging youth about some of these topics. If they're not seeking treatment, right? So if they're wanting to discuss a hypothetical, right? And talk about what is going on with respect to their situation, and would that be something that was disclosed on my medical record? These are questions in grayness in the law. And again, not legal advice, because that could get you in trouble. You would need to talk to your legal department. But there are ways to have these conversations with youth outside of the formal treatment process. Yep.
I just have a question. So I'm a clinical social worker. So, but when I think of peer mentors for youth, my impression is that the youth and the peer mentor have a relationship based on open sharing and confidentiality, and that the youth isn't going to think that peer mentor is going to. That to me seems almost more sacred in a weird way. Yep. So what are the guidelines?
I think that's what I was trying to get at. Okay. Is that as a peer mentor, that is a space, right? Having engaged. I mean, we see this in SBHCs, the medical assistant, as having a space for sometimes for youth to talk through their rights. And I think that's really important. And that relationship is really important. Yeah, thank you for bringing that. You said it much more eloquently than I did. Okay, we have a couple more slides, but this is great. This is exactly what we wanted. Okay, so pro tips for youth engagement. And so about 35% of my job is working with our statewide youth advisory council, and they tell us how to do our jobs better, which is really important. And so I would suggest that for everyone. If you are working for a health system, or you are working for a school, or you are working for just directly for a CCO, having a youth advisory body of some sort, and I would extend that to a youth and family advisory body, where some of these issues can be talked out more and developed more, and the caveats of folks' lives can be more in the conversation, is really important. And so I really want to stress that as something that we have gotten a lot out of, and doing that authentically and engaging. It's cheap, but it's really hard. And so there are other ways to do formal advisory or some other youth engagement to really get at your policy and practices. The second thing is youth-friendly guides before the visit. So we are in the process of developing the document that we have. Our youth are tearing it apart right now. And then we're going to take it to our Department of Justice and see how much of it we can put in publish, but I'm pretty sure a lot of it, with explicit things that are language that makes sense to youth, that they understand the real complexity of what happens in each clinic space when they show up, how they show up, and really so they have a clear, informed understanding of the consent and confidentiality statute. Third is communication before, during, after. So we've talked a lot about the before part, should be all the way through the process, especially if you think about the behavioral health statute with respect to consent. Is we have to involve the parent by the end. So understanding that throughout the process is like, we still need to talk with your parents, we still need to engage your guardians. That's important. Yeah. After that, I actually couldn't hear what you said. I'm sorry.
I was just asking, what if the peer no longer trusts you and they no longer want to talk to you anymore after that? If that makes sense for the situation, because that's very common for what I've experienced. So
after the discussion of what is going to happen, yeah.
They're like, why would you do that? Yeah.
I think that's why that's why the first part's so important, right? The engaging upfront, right? And so I would rather have a transparent knowledge, and we would hope that youth would rather have transparent knowledge before even beginning that journey, that they know what the statute is going to end up. And that might disengage. It's true. It might disengage. And that gets a lot back to the point around stigma and the bigger conversations that need to happen within the clinic and the school setting. But I don't have a good answer of immediately for having that conversation and no longer being trustworthy of the system.
Yeah, because a lot of my peers, I don't directly contact their parents or anything, and I let them know that straightforward. I would usually contact their provider of some sorts or their therapist, and then maybe be like, hey, I've just been kind of noticing that they've been kind of going through some stuff right now, just kind of keep an eye out on them. But then from that point, they can notify their parents or something, and then that's when, especially if they have issues with their parents, that's when it gets a lot more complicated.
Yep.
So it's one of my peers right now is kind of just why would you do that? Now they know one of the biggest and only people that they trust, they no longer trust, and they feel like they can't trust anyone now, because every time they tell anyone how they're actually feeling, it gets turned around and makes things worse for them. So it's kind of a lose-lose situation, because they share their feelings and then they get in trouble, they don't share their feelings, and then it makes them feel bad. So I feel like there isn't really an afterthought or after step after this.
I think it's a very valid point and something that we're going to ask you all about. I think this is an ethical dilemma, right? And I would say also is that the caveats there are caveats to the law, right, around abuse. I think the reproductive health caveats are much broader. That gives a provider a little bit more discretion for non-disclosure, although they may or may not advise anyway. There are specific services that they do have to advise. Unless those caveats exist. So yeah, we will talk a little bit about that when we have our next activity, if we have time. We're just doing it. So clarity on reporting requirements is important. We talked a little bit about mandatory reporting, so weaving that in with the consent and confidentiality statute. Destigmatized settings, again, that is something that we have heard loud and clear from youth. It's making the most either providing the services in the most youth-friendly environment as possible, engaging youth on what that looks like, and then encouraging engagement with trusted adults. That is not only, it's the law and for behavioral health, but it's just best practice. It's really to engage the folks who are going to support them once they leave your supervision. So those were my big ones. Do you have anything you want to add to that list?
Just back to what you were talking about losing trust with people and, alliance deteriorating, things like this, is just reminding people that we work in a pretty weird system. And I don't have the power to change that system, but I am here to support you. And so you have the right to come in and get help whenever you want. I do have to work within this system, and these are the laws for my ability to practice, right? And just letting that be up to them. It sucks, it's really sad, and it's just part of the conversation that we have to have with people, right? I'm not a system changer social worker, I'm more of how do I make this system work for me?
So, there's been a lot of great discussion, but in case there wasn't, we got an activity. So, we have these great tables, and thank you to Tatiana who showed me the space before that I knew there were tables. So at your table, we want you to have some conversations around how confusing this is, how hard it is to keep a client's trust, and some of the kind of caveats that we've talked about today. So, and then to see what the scope of training that you all have had. So we would like you to have a conversation. So if you could pick a note taker, that's great. I see a lot of you have pencils and paper, so that's great. And discuss these questions. We have, what trainings have you received on minor consent policy and procedure? What is needed? What are some ethical dilemmas related to consent to care for SUD? How is your organization engaging youth on consent and confidentiality policy and practice? And then anything else you want to say. And then I think we'll do that for about 15 minutes, and then we'll report out for 10. I will take some notes as well while we do that, if you don't mind, because again, one of the things we want to have, our consent is very complicated, and we really want to make it where there is less confusion and barriers for the providers, also confusion and barriers for the youth who are seeking services, and having conversations about it. What are the what's the vagueness of the law, and where it seems like very treacherous or the terrain is very rough, is important for us to, as policymakers, to do better. So that's what we're gonna do. We'll give you all about, let me make sure. Yeah, 12-ish minutes, and then we'll come back at 10:30. Does that sound good? Thank you.
So we're gonna bring it back. It sounds like y'all are having really good conversations, and I can't wait to hear what you all talked about.
Hello. Okay, so if you have someone who is brave enough to present for your group, we would love that. We've been asked so that this can make for better viewing for our friends who are seeing the recording. If you could come up and speak, we'll have a microphone up front. If that is too daunting, we will pass the mic around. So who wants to go first? Oh, okay.
Hi. Oh, I'm like standing right in front of that. My name's Jay, and I was with that lovely group right over there. And so some of the things that we talked about, the first one that we touched on was actually about the ethical dilemmas related to consent to care. And one of the topics was, what if the client shows up under the influence? And I know that this is a little bit different when working with adult clients. We're able to have the conversations around like, you know, this isn't gonna be as effective, but let's continue if you want to. With youth, though, it gets a little bit trickier, especially with mandatory reporting requirements. Tristan brought up a great point that these youth may share something while under the influence that they normally would not have shared, and especially considering they're a vulnerable population, that makes it really difficult when it comes to like mandatory reporting. So having conversations early on with consent and what it means, like if we suspect that they are showing up under the influence, what that means for how the session will go forward. That was the main ethical dilemma that we touched on there. And then, how is your organization engaging youth on consent and confidentiality policy and practice? So this is something that, at least at the organization I work for, we talk about first thing upon intake, but it is also something that needs to be ongoing. So some organizations that, I think Morrison was the one that most of the people work for at the table I was at, but it's an ongoing thing where like, you know, you talk to youth, like if, you know, if it's getting into that territory of like, they might be starting to talk about a topic that requires mandatory reporting, just reminding them like, hey, just so you know, like this is what we talked about before, but feel free to continue sharing if you want to. Really trying to make it like an informed process that they are a part of as an ongoing practice. And with that, what trainings have you received on minor consent policy and procedure and what is needed? Just speaking personally, I do receive quite a bit of training at team meetings and ongoing trainings about mandatory reporting, ROIs, confidentiality. But I do think it would be good to have like role-playing conversations. That could be like an additional exercise that is done, mainly just because like, for me at least, like rapport building is so big that I sometimes forget how to have serious conversations with youth. So having those like practice conversations with my coworkers so that I know that what I'm saying is accurate and is going to be informative for these youth is just really important. And one of the other things that we were talking about under the anything else considerations is just culturally speaking, for families, especially like families of color, immigrant families, they don't understand a lot of the processes that go on in this country, especially things like mandatory reporting. That's not something that's like universal. And for especially immigrant families that aren't from this country, and especially families with language barriers, it can be really daunting and scary to consider that there's a system that exists that could take away your child if the state decides or whoever decides that what you're doing is not enough to meet their safety needs. That can be really scary, and that can make parents maybe not want to engage as much. So I think it's really important to consider the cultural implications of mandatory reporting, the system, and you know how that can be oppressive to certain groups. And just really try to consider that when working with families from culturally specific backgrounds.
All excellent points, thank you.
Yeah, so I work at Clackamas County, and we've actually had a lot of training recently about minor consent and policy and informed consent and just the struggles with being an integrated medical system. We use Epic, so we have MyChart and things like that, and there was an incident of a student who was receiving mental health at a school-based health center, and their parent had opened a MyChart account at an off-site clinic, and they were able to see all of their notes. And so it opened up a bigger conversation around like, how are we kind of protecting those notes? How are we doing the best we can? And the concept of confidentiality, and like, can we really say we're confidential when we can't really protect their notes from being seen by a really nosy parent? So there's, we went through a lot of training of just like how to have conversations really that are focused on what we share and what we don't share, and what are the limitations, and that, you know, if you have a really intense parent, they can get a hold of your records, and hopefully if you have a really great records department, they will reach out and they say, hey, so-and-so requested these notes, do you have any concerns? And just really having a lot of communication across different departments to make sure that we are being conscious of safety, things like that.
A couple other things we talked about was just different clinicians' take on when substance use gets into harm or safety concerns, and how that can be an ethical dilemma that comes up with youth. And at least at my organization, Metro Pediatrics, we have a conversation with youth around age of 14 about proxy access and my health. And then we talked a lot about just different note statuses, like sensitive notes versus blocking the note in my health. And at least for me, I feel like it's opened up the question of needing to learn more about what those different types of blocking notes means for records requests.
I highly recommend getting to know your records department and having these conversations with them, because in theory they should be asking before they're releasing behavioral health records, but that doesn't always happen, especially in an integrated setting. So I would make friends with them and get on first name basis.
Hi, I'm going to answer the anything else box up there because it seems like it's coming up a lot. So we have 2 staff who are outpatient therapists with Clackamas County, and then 2 who are partial hospitalization at Providence, which was actually really, really helpful in terms of the documentation piece that we're talking about. And so my argument is that content of therapy sessions is not really necessary to go in the note, right? The things that are necessary to go into the note are mental status, how is the kid doing today, changes, like both progress and challenges. And why that was helpful to have this conversation at this table was because what I think about is, what do I need to put in a note that is going to, if necessary, justify a level of care change, either for mental health in this case, because they're mental health providers, or residential. So things that I will put down in a kid's note is you know, in the last week, 5 panic attacks. In the last week, no panic attacks, right? If that's something that the kid has. No substance use this week. Marijuana and cocaine use this week. Things like that, because and suicidality, right? How many suicidal thoughts? How often are they having active or passive suicidal ideation and self-harm? Because what I want to be able to do is I want to be able to send people notes, you know, here's a few months of notes that show that this kid has had increasing risk in whatever kind of way, and this is how. But it doesn't need to be the whole content of the story. It's just, this is what's happening. And then I believe that CareOregon likes me to say what evidence-based practice I am doing, so people know I'm legit and they will pay for me to work. So, you know,
Look at you making that system work for you.
I know, I'm really good at that actually. So I used CBT, DBT, MI, whatever it was, to talk to the kid about social skills, healthy relationships, conflict at home. I don't need to write down what that conflict was. And then the kid's participation is active, engaged, wanted to talk about relationship with dad, wanted to talk about relationship with partner, wanted to talk about stressors at school, and then what the homework is, so that way I can remember, what are we working on next week? And that's it. It's about 8 lines total. And if a parent looked at that, if we put it up here, if it got read in court, that would be fine, because the kids' content of their thoughts and feelings are not in my notes. And I've been doing this for 8.5 years, and I don't think I've ever had it rejected by insurance. So make your life easier, guys. Come this way.
100%. Thank you. The last thing that I wanted to say as we wrap up, just because we were talking about the legal department and medical records, everybody has their own different legal department, and your legal department has its own interpretation of the law. So I get in fights with people all the time about releasing information between medical and mental health, because that's okay, right? But lots of people don't know that, and so just look to your legal department and see what are they doing. Anything else you want to add?
Yeah, and just on that, it's like everybody has their own strategies, right? And so when you are thinking about taking a new strategy or approach, again, running it by your legal department is the most important thing to do. You want to protect yourself as well. So that's it. This has been wonderful. We really appreciate you all coming and sharing, again, what is a very complicated and hard topic. So yeah, I think we'll end it there.